So I just want to pick up from what Nadia said and also what Dr. Kurtz said. This is really something that's a little different than the typical tumor board that you've heard about maybe from your providers, in that we don't treat the tumor, we treat the patient. And we wanted to really make that distinction here. So we're excited that we have some members of this group that are both not just the typical neuro-oncologist, neurosurgeon, radiation oncologist, but we've expanded it. We've also are really pleased to have someone from outside NYU come here who's very well known. So I'll start, of course, Dr. Kurtz is here, who you've heard a lot from, and Dr. Kurtz is the head of our neuro-oncology group and really leads most of our clinical trials here. So Dr. Kurtz, take the stage. And now we're really honored to have Dr. Tony Wang, who's an associate professor from Columbia uptown, and a really well-known radiation oncologist that only treats the brain, and we're thrilled to have him here to lend his expertise. So thank you, Dr. Wang. Demetrios Plakatinakis is an outstanding physician-scientist, neurosurgeon, well-respected in our community here at NYU, but also nationally, and we're really honored to have him join us at the panel. Dr. Tumor Press is a psychologist here at NYU, and having Dr. Press here is, I think, really exemplifies this idea of not just how we treat the tumor, but how we're treating the patient, and so we're really honored to have Dr. Press join us. And Minerva Utate is a nurse practitioner in the neuro-oncology group who, if you've been a patient here, Minerva is the front line. And we're really, I think this is really very, very important to understand how we incorporate the individuals that are providing that day-to-day interaction in the treatment plan. So, Minerva, thank you. So I am just going to, hopefully not, but let's see. There we go. Okay, so what we're going to do is we're going to go through some examples, two patients. They aren't necessarily exceedingly complex in the way that they presented, in the decisions that need to be made by the panel, but that really isn't the point. It's really how we address the individual aspects of that patient's needs, and so I will introduce the case and then invite the panelists to comment as we go, and I don't think there'll be any fighting. I think it'll be a very friendly crowd. So our first patient is a 57-year-old woman. She's a widow. She unfortunately has no children, so she's on her own. She works as an administrative assistant. And on May 2nd, 2017, she suddenly had seizures at work. Never had seizures before. It was witnessed, so it was public. People saw it. She came to the emergency department here at NYU, was given a medication to prevent seizures, which some of you may have heard of. You may have heard of the name Keppra, the brand name. And they did a CAT scan of the head, and that showed a potential tumor or growth in the brain. So that prompted an MRI. So this is kind of a standard approach when someone shows up in an emergency room. The first thing you want to do is rule out maybe a stroke, so they often do a CAT scan. And once they see something that looks like it's pushing the brain one way or the other, it's typical then to get an MRI. And this is what the MRI showed. So this is a brain MRI. Many of you have seen these before, but I always like to provide some introduction. The front here, you're not seeing my arrow, there we go. The front here is where the eyes would be, and this is the back of the head. And so the brain is being sliced in a computer like a loaf of bread. So we're looking at one slice here. The slice on the left is showing fluid or swelling, and the slice on the right is showing what we call contrast enhancement. What happens is a dye is injected into the patient. This dye will seep out of the circulatory system of the blood vessels where the blood vessels leak, and it turns out sometimes blood vessels leak in tumors, and so that's why we use that dye. The dye only shows up in MRIs, this particular dye, so that's what was done. So if you look on the left, you see this white area on the left side of the screen. Now the doctors know that the left side of any image is always the right side of the patient. It's like we're standing at the foot of the bed looking at the patient, and so our left is the patient's right. So that's the white area. And then the area with the arrow is the little area of enhancement where the dye leaked out into the tumor. So this led the radiologist to think that this might be what we call a primary brain tumor, a tumor that starts in the brain, not a tumor from another kind of cancer elsewhere in the body like breast cancer or lung cancer that then sent cells into the brain to form a tumor. This is one that started in the tumor. And to continue on, the patient's MRI, as I said, showed a tumor in the brain. And now I'm going to turn to my neurosurgical colleague, Dr. Plakatanakis, to talk about the next step.
Can you hear me?
Give it a little tap. I'm not sure make sure it's on.
Can you hear me now?
No.
How about now? Okay,
Yes.
It works. Okay, thank you, Eric. So as you said, the MRI is suggestive of a primary brain tumor, and the first thing that comes to mind with a patient like this is what we call a glioma, or perhaps something called glioblastoma. It seems, based on the history that we heard, that the imaging that we saw, the MRI, that the tumor is involving perhaps some of the areas of what we call the motor part of the brain. So maybe some of the areas that control movement of the face. One thing to keep in mind, and probably a lot of you are familiar with this concept, is that the right side of the brain controls the left side of the face and the body, and vice versa. So it's possible that this tumor, if it were to progress, it could affect movement on the left side of the face or even the left arm. It seems also that most of the tumor is not letting the contrast into the tumor. The contrast is not leaking through the blood vessels. And we do see that sometimes in certain gliomas and even certain glioblastomas when they're early on in their evolution. The surgical goal, in most cases, is to go after the contrast enhancing, we call it, portion of the tumor that shows bright on the image on the right-hand side. And that allows us to take out what we think is the most aggressive, most advanced part of the tumor, and also get a diagnosis. In other cases where this contrast enhancing portion of the tumor is larger, we're trying to go after the whole area if it's possible, if it's safe from the neurologic point of view. Also from the surgical point of view, the area that looks bright on the image on the left is probably too large to go after. This is what we call the more diffuse, the diffuse portion of the tumor, and it's probably a little harder to remove. So as a surgeon, I think I would go after the part of the tumor that's bright on the right-hand side.
And can you comment, and maybe Dr. Kurtz wants to comment as well too, about the way this patient showed up in terms of how often are seizures associated with tumors like this, and how often do tumors like this have seizures?
Sylvie, do you want to start?
Yeah, so seizures are a very common presentation of brain tumors, and actually, yeah, it's one of the most common presentations that we see. And the tumors, it depends a little bit on terms of where the tumor is located, how prone to seizures the tumor is the patient making to be. There are certain areas of the brain that are very irritable, and seizures are very common, such as like the insular region or the temporal lobe region. Other areas of the brain would be more likely to present with other symptoms like weakness, gait imbalance, depending on where the tumor is located, such as the frontal lobe. But nevertheless, pretty much any area of the brain can cause seizures, especially if there are areas involved of the brain that we call cortex. That's the gray, so to speak, gray matter of the brain that you may have heard about. So we do see seizures very often. And often, seizures are really the first sign of the tumor, even before the tumor had actually time to cause weakness or other neurological symptoms.
Great. And one other comment for Dr. Plakatanakis, one question for you. What would you be telling the family and the patient before surgery that they can expect in terms of their recovery after surgery?
So for a procedure like this, I would warn them that there's a chance that the left side of the face, maybe the left arm, may be affected by the surgery. It's a little hard to tell without more images from the MRI, but sometimes we would consider doing what we call motor mapping, trying to identify the parts of the brain that control movements so we can avoid them during surgery. And sometimes for motor mapping can be done with a patient asleep, or sometimes it's done with a patient awake, so we can monitor the movement on the left side of the body live during surgery.
Great, thanks. So the patient had surgery, and fortunately, after surgery, the patient recovered quickly, and there were no more seizures after surgery. Briefly, I'll just show you what the tumor looked like under a microscope here. This is actually a microscopic view of the tumor. It has some of the classic hallmarks of glioblastoma, the sort of pink areas in a circle there, which are some of the new blood vessels that are formed that the tumor needs in order to provide nutrients to the tumor, so they form new blood vessels. This is one of the hallmarks under the microscope of glioblastoma. The blue, dark blue dots are the tumor cells, and there's a lot of them, so we can see those kind of clustered together. And then there's some molecular features of the tumor. One is we look often or always now for mutation of a gene called isocitrate dehydrogenase. There's actually a couple of genes. We call them IDH genes, and it's necessary for the diagnosis to have that information. And so in this case, the IDH genes were wild type, which means that there was not a mutation or a change in that gene. And that's part of the way we kind of classify and think about glioblastoma. There's another gene called the epidermal growth factor receptor, which was not amplified. So in some glioblastomas, this gene there are many, many copies, extra copies of this gene inside the tumor cells, but that was not the case here. And then the last thing involved an area that regulates a gene called the 06-methylguanine DNA methyltransferase gene, which is a mouthful, but we call it the MGMT gene. MGMT gene makes a protein that detoxifies the chemotherapy that we use to treat this tumor. And so when the gene is methylated, it means that it's been turned off. And so when it's turned off, we think that therefore the chemotherapy will be more effective because it's not able to make the detoxifying protein. In this case, it's unmethylated, so it's turned on, in which case giving chemotherapy may not work as well because it can detoxify the effects in the tumor cells. In normal cells of the body and of the brain, there's normally expression, or this protein normally exists, so normally it's unmethylated. The tumors sometimes methylate in order to shut off production of this detoxifying protein. We also sent some material to a company that does a bunch of genetic tests of the tumor, and they found that there was some other changes involving some other genes, but none of these are really driving treatment, though. I'll let Dr. Kurtz talk about that as we move forward a little bit. So we have this tumor, and the formal way of defining the tumor diagnosis is a glioblastoma, World Health Organization grade 4, IDH, wild type, MGMT unmethylated. So now let's talk about the treatment plan. So we'll first go to Dr. Kurtz and talk about what you might propose presenting this case.
All right, so in this patient with an MGMT unmethylated glioblastoma, this so-called standard of care, meaning the best established treatment that is available, still is like radiation plus temozolomide chemotherapy. Alternative to that would be participation in a clinical trial to evaluate like novel ways of treating these tumors. In this case, I want to speak a little bit about what Eric already alluded to, the MGMT methylation versus unmethylation. Yes, it is, we know from many studies that if the tumor is MGMT methylated, we are very confident that the chemotherapy called temozolomide or Temodar is going to be useful for the tumor. We're less certain about the efficacy of the chemotherapy if the tumor is MGMT unmethylated. Nevertheless, the studies also have shown that there is always some patients who even have MGMT unmethylated tumors that still derive a benefit if temozolomide is added to the radiation treatment. And therefore, we usually always recommend a combination of the two treatments, radiation plus temozolomide, unless there was a clinical trial available to the patient. So in this case, I discussed this with this patient, and we went through the pros and cons of each of these treatment approaches. We went through the clinical trials that were available at NYU to this patient, and because of some and other reasons, she was not eligible to participate in a clinical trial here. This patient also went on for obtained some second opinions at other institutions. There was not another clinical trial that was available to her either. And therefore, based on what I said, we decided to move forward with the plan for radiation and chemotherapy, the temozolomide.
Great. So why don't we ask Dr. Wong now to comment on the radiation that you would give a patient like this?
Yeah, so the radiation generally for a patient with this diagnosis and the age would be about 6 weeks of radiation therapy. It's once a day, 5 days a week for 6 weeks. I tell patients with this kind of diagnosis that generally each day the radiation treatment's about 15, 20 minutes each day. The actual delivery of radiation is rather short, usually less than 3-4 minutes. And then before the radiation is given, there's a procedure, we call it a CT simulation, which is to have a patient come and do a CAT scan, but that also includes the making of a custom-made mask. It's made of aquaplast. The purpose of the mask is to restrain the patient such that when radiation is being delivered, the treatment's being delivered accurately to the part of the brain. And so generally speaking, to go into detail, the radiation is delivered really to the postoperative cavity, and we use the most recent postoperative MRI scans to help us delineate where the radiation is going to be delivered. It's just really focused to that cavity and possibly some of the potential microscopic disease with a margin around it.
And Minerva, could you comment on some of the teaching that you give patients on the, on the taking of the temozolomide and the education that's provided?
Sure. I usually bring in the patient and discuss everything, pretty much. I'm their support system, the nurse practitioners. I work with some, and Sylvia as well. I will let her know that the Temodar is not picked up through a local pharmacy, like CVS. It has to come through a specialty pharmacy. Pharmacy liaison will obtain all the authorizations that are required, and the insurance will dictate which specialty pharmacy it'll have to be prescribed through. After the specialty pharmacy receives the prescription, they will call the patient and deliver it at home. It is important that the patient knows that Temodar is taken on an empty stomach for 42 consecutive days with radiation. I will review expected side effects, keeping in mind that she may not have any of these, but she will be monitored closely by everyone on her care team. After she completes the Temodar and the radiation, she will have 4 weeks off just to recover, and then we will bring her in with another repeat MRI, and she will meet with the team again and discuss adjuvant chemotherapy. But most importantly, I want her to know that I will be there through the entire process to support her, and she's not alone.
Excellent.
Yeah. I want to just echo on this, and just want to emphasize one point. So often, like when patients come to us with this first visit, and of course this is like a diagnosis that's putting life upside down, I just want, and it's very confusing often to patients, who's who and on my care team. Am I the primary person? Is it a surgeon? Is it a radiation oncologist? So I just want to highlight that this is a multidisciplinary team approach, and all the specialties that are sitting on the table here work very closely together. It's a tightly knit team that consists of like the surgeon, the radiation oncologist, myself as the neuro-oncologist, and each of us has like their teams that work with them, such as my nurse practitioners, nurses, Minerva, Sylvia Crispinos in the audience. But then same people are present on the other teams, like neurosurgery teams and the radiation oncology teams, and they're really kind of the quarterbacks on the teams, right? So if you have any questions, because this is like all so much confusing information, you should feel free to reach out to your teams, and Minerva is in ready contact with the patient throughout this radiation and treatment course, and if there are any side effects, any concerns, anything, I forgot how to do this with the temozolomide, you should feel free to reach out, and we will be happy to explain this.
So, Dr. Press, what are some of the challenges, and how might you address them in this patient that doesn't really have a support system kind of built in, doesn't have the family to kind of help her get through this, and may have some issues, depression or whatnot that they're dealing with, but just how to kind of handle all of this?
So, sorry. For this patient, we wanted to provide her with the opportunity to talk about any type of emotional reaction she was having to the diagnosis, and that's a very normal thing to experience, a strong emotional reaction to getting a diagnosis like this. So in terms of her support network, which is always really important to assess, is a person's support network, and to strengthen it if possible. This patient had some friends, but she was estranged from her family, and she quickly made it clear that she wanted to be reunited with her family. And so we spent a lot of time repairing her relationship with her family so that the family could support her through this ordeal. And we also worked with her in terms of, because she was working full-time, so how can she continue to work? That was very important to her. We provided her with information about the Americans with Disabilities Act and her rights in terms of workplace accommodations.
Excellent, yeah. And okay, so the patient underwent treatment with radiation and temozolomide concurrently for 6 weeks at the same time, and then had the month to recover from that and came back. And then now there's a decision about the next stage, what we refer to as the adjuvant stage of treatment. And so maybe Dr. Kurtz and Dr. Wang could comment on that, and also talk about the use of tumor treating fields and when that decision is made.
Yeah, so once the radiation is completed, like that will be 6 weeks into, after the treatment started, there's typically a 1-month break. And that 1-month break is really important for patients because that's when they really recover. Towards the end of the radiation, common side effect from treatment is that patients do feel fatigued. So that month is really important for patients to recover, and usually patients come back after that month and see me in clinic and do feel really well. They typically will say things like, now I feel almost close to back to where I was before I was diagnosed. And then at that monthly visit, we then will discuss, what are the next treatment options, or what is the treatment plan looking like moving forward. So until 2015, the standard of care treatment would have been to continue on monthly cycles of temozolomide. That will be the same chemotherapy drug that is taken every day during the radiation, but at a higher dose. Instead of taking it every day during the 6-week course of treatment, the patient would take the same drug at a higher dose for 5 days. And then you're taking the drug for 5 days, 23 days off, 5 days on, 23 days off, and so forth. And then since the Optune or Novocure device came out, the other option to add on to that treatment approach would be to start treatment with Novocure. So that is now an FDA-approved treatment that is recommended for all patients, and now it's even covered by Medicare. So that will be like another add-on option. We do discuss this with patients. I will say that like some patients will take it on and some patients won't. There are certain cosmetic concerns that people have. I will say that I have had very motivated, even female patients who kind of are very committed to this treatment, and they make it make an effort to come in with like the prettiest scarves that they have. They look fantastic and they're very committed to treatment. So this is one way of adding on to the temozolomide treatment. In this particular patient, as Tamar was saying, it was very important for her to go back to work, and she was also a very private person, so she didn't want to for her, the cosmetic implications were very important, and she therefore decided not to do the Optune treatment.
So I want to first just point out that I do serve on the advisory board for Novocure. But with that, I just want to talk about the radiation part, which is that during the 6 weeks of radiation, typically in my practice, I will see a patient once a week during their radiation therapy. If they're not on a clinical trial, we will usually do blood work once a week, checking fluorescent blood counts. In some patients who take the temozolomide or Temodar, there's a small minority of patients who may have a drop in their platelets, and so we usually monitor that. But in general, most patients who undergo the radiation phase of 6 weeks tolerate it just fine. I have many patients who either are working during their treatments, and so my experience, the typical side effects are usually hair loss and obviously fatigue. And then usually, most frequent questions I usually typically get from patients who are undergoing this treatment is, is it gone? How's it look? Is it responding? And my answer is pretty much always the same, is that typically at our institution, our protocol is to repeat an MRI scan about 1 month after the radiation is over, or after chemoradiation therapy is over. I tell patients that if we do an MRI scan again during the treatment or immediately after the radiation, generally speaking, it's a little more, there's a lot of noise and signal, and you might not get a lot of information. So typically the way to we try to assess our some sort of new baseline, I would say, not necessarily even a response, is just to get an MRI 1 month after the radiation is over. And then they'll ask me if they'll come back again, do they need more radiation? And my answer is generally no, there's really no plans to come back for another course of radiation after that.
Great. So this patient completed 4 months of that higher dose temozolomide, and then came back for a follow-up MRI in December 2018. And this is what the MRI showed. There was concern at this point for recurrent tumor at the site of the original tumor. So perhaps Dr. Kurtz, you want to comment on the MRI and what this might mean?
Right, so the MRI scan shows new, what we call enhancement, meaning uptake by the contrast agent at the same place where the original tumor was located, in this right frontal parietal region. There is associated T2 flare, that means swelling associated with this region, and overall this is concerning for the tumor having grown back. So this is now tumor recurrence. And so I want to comment on what Tony just said. So although they will usually not see patients will not see radiation oncology as readily, they will still follow up with me, usually on a monthly basis. Every 2 months, we do MRI scans, and this was the regular bi-monthly MRI scan that we always obtain on patients who were diagnosed with a glioblastoma. And then this scan was demonstrating that the tumor had come back. The patient, in terms of symptoms, had actually felt a little bit more fatigued, but otherwise hadn't experienced much new problems. There was not like worsening weakness. She had a little bit more trouble at work, so she was working up until that time point, a little bit more trouble with concentration, felt like more exhausted at the end of the day. Otherwise, she had actually felt pretty okay, but nevertheless, that's one of the reasons why we always do those scans, because we want to have a close surveillance and a close eye on the patient, how they're doing. So these visits with me are always anxiety-provoking for the patients, very understandably, and this patient was very anxious, very upset about the fact that this tumor now had come back, and we had a long discussion about, what the potential treatment options would be. At that time, we also discussed so-called standard of care options, like other chemotherapy approaches, like Avastin, CCNU, other treatment options, but we will always discuss the potential of participating in a clinical trial. So for this patient, she was not eligible to do a clinical trial when she was initially diagnosed. However, when the tumor had come back November, she was eligible to participate in a clinical trial that was offered at NYU at that time. That is actually an exciting study, like a type of immunotherapy treatment where we use an attenuated virus, so to speak, that is used as an envelope where we package a certain pro-inflammatory molecule into the virus. The one caveat of the trial was that she would have to go through another surgery because that virus needed to be injected into the tumor cavity directly, and that was a challenging conversation to have because the patient kind of had been determined she will never go through a brain surgery again. But ultimately, we're very hopeful about these immunotherapies, and at that time I counseled her and I said, look, these Avastin treatments, the chemotherapy options, they will always be available, but this hopefully promising new treatment with the immunotherapy is available to you now. And she had such a good recovery from the first surgery, and in speaking to my neurosurgery colleagues, they thought that she would have like a similar recovery with this new surgery. So we were then able to kind of talk about it, and ultimately the patient decided to move forward with this clinical trial.
And Dr. Plakatonakis, if the patient had not been eligible for a clinical trial, what about surgery for this patient?
Great question. If we convince ourselves that this is tumor coming back, sometimes it's not so easy to decide whether it's actual tumor or whether this is an effect of the treatment. But if we convince ourselves that this is likely to be tumor coming back, we do consider surgery, even if there's no clinical trial associated with that. And different surgeons, different centers have different criteria, perhaps, that they consider before deciding whether to offer a patient surgery for a current tumor. But some of the things that almost everybody thinks about is, number one, is what is the functional status of the patient? So if the patient is doing well, as we heard about this patient, that suggests that the situation is conducive to considering additional surgery. Number two, is the tumor localized in one area or is it diffuse? If the tumor is diffuse, if it's in multiple areas, it's a turnoff for a surgeon because the concept behind that is you want to treat one area with surgery, but if there are other areas that are not going to be treated surgically, you're not achieving much by removing one area of the tumor. So it looks like this tumor is localized, so she would potentially be a candidate for another section, whether there's a trial or not. Number three, is it still in a safe area? And it looks like the answer is yes. The patient tolerated the first surgery well. The tumor is coming back in the same area. So I think that's also positive in terms of considering another resection. So even if there were no trial available, if the patient is doing well, the tumor is localized, and it's still in a safe area, we would still offer the patient, most surgeons would offer the patient a new surgery. And what does that accomplish? That sort of creates, you're hitting reset, essentially. You're removing as much tumor as possible with surgery, and you're giving a new type of therapy a chance to work.
Thank you. And Dr. Press, when these patients who have recurrence, I think they face some new issues they didn't have at the initial diagnosis. Do you want to comment on that and maybe how you support them with that? Oh, grab that mic, please. I'm sorry.
This patient was particularly upset that the tumor came back, so we had to just talk her through it and, remind her that having an emotional reaction is normal. It's normal to feel overwhelmed. It's normal to feel depressed or anxious or scared, and it's normal to be unsure about what the best decision to make is. And so I work with the patient and with the entire team to make sure that the patient is comfortable with how they're proceeding and feels good about their decisions.
Excellent. So Dr. Kurtz is actually going to talk about this specific trial, I believe, during your talk. Will you be covering this? Yep. So we won't go into the details of the specific trial, but I did, before we have one more case I'd like to get to, and I just want to point out that so far this patient has done very well with this trial, underwent a resection, a tumor and then had this virus injected and has continued on this clinical trial and was last evaluated September 10th, so just a week and a half ago. And the MRI looks very promising. There's no evidence of tumor growing back in the area where the surgery was, and there's a very limited amount of that's fluid or swelling around the old site. And I think just as importantly, if not more importantly, than the MRI really, is that this patient continues to live independently, continues to work part-time, and has built up a good support network to help her through. So this is the sort of outcome we try to achieve as a multidisciplinary team. So I'm going to switch to the next case. Dr. Kurtz has provided us this lovely picture to kind of regain our thoughts here. So the second case is a 42-year-old man who has a family and works in finance, something you never find in New York. And on September 12th, 2017, had 2 episodes of word-finding difficulties. So this is where they just can't come up with the right word. It's not the same as not being able to kind of name that person who starred in that movie from 1986. It's a little more complicated than that, and it's really not being able to find even ordinary words and conduct a conversation. And with that was some numbness and of the right hand, so that means sensation was affected, but also clumsiness, so movement of the right hand was affected as well. Also noted that he actually had this in the previous month, but it went away and just kind of thought, won't deal with it now, had a lot of travel to do, and so kind of deferred it. But eventually came to NYU. That's our abbreviation for NYU Langone Medical Center. It doesn't spell Neolmic. And there was a concern when he was seen that this may be seizures, and so an MRI of the brain was obtained. And in this case, I'm going to have Dr. Plaka-Tanaka's comment on this MRI.
So the MRI shows a large tumor. It's suggestive of a large tumor on the left side of the brain. Again, as Dr. Solomon explained in the prior case, if you look at the image on the left, for example, the eyes would be at the top, the back of the head is at the bottom of the image, and the area of the white cloud is actually the left side of the brain. Why is this important? So the patient is having speech problems, and it turns out, and I presume he was right-handed, so in the vast majority of people who are right-handed, language and speech localize to the left side of the brain. So this matches some of the symptoms he's having. He's having problems with his speech. There are intermittent episodes of speech difficulty, and then they go away. He's also experiencing clumsiness and numbness in the right hand. And that makes sense based on the imaging because the more posterior aspect of the tumor, farther back, may be going into the areas of the brain that control movement and sensation in the right face and the right hand, possibly. Remember, as we said in the first case, the right side of the brain controls the left side of the body, and vice versa. So the other thing we know about this tumor is when you look at the image in the middle, this is an image where the patient has been injected with a contrast at that time intravenously. There's no contrast leaking into the tumor. So what I'm thinking right now is that this patient is this relatively young patient. He's having a primary brain tumor of the brain, a glioma, most likely. And we're thinking that he has a particular subtype of glioma that happens in younger people. And those gliomas are identified by mutation in a gene that Dr. Solomon mentioned a few minutes ago. It's called IDH, or isocitrate dehydrogenase. And these tumors have a different behavior than the tumors that we saw in the first case.
And what about this MRI all the way on the right here with the fanciness? What is that?
So this is a specialized form of MRI. It's called functional MRI. And I'll explain what it does and why we obtained it. So we were suspicious based on the location of the tumor in the first two images that it involves the speech areas of the brain. And we have the ability to obtain these images called functional MRI. And what happens is during the functional MRI, we ask the patient to perform behavioral tasks. And in this case, we ask the patient to complete sentences or generate verbal output, generate words or verbs, in order to use the MRI sequence to identify where his speech center is. So if you look at that image, you see the pseudo-colored areas that happen to be actually right in front, in the front part of the tumor, and that's the area of his brain that generates words or verbs. So we know that part of the tumor involves the speech area, and again, it matches his presentation with speech problems.
And as is typical, you would get a call as the neurosurgeon about this case, and so how does that information affect the kind of surgery you performed on this patient?
Yes, so with this kind of information, you would think about doing a surgery that's guided by functional mapping. What does that mean? The functional MRI provides important information. It suggests that the front part of the tumor involves the speech area. However, the fMRI is only about 80% accurate. And we have better ways of assessing surgical outcome in terms of speech preservation. So when we talk to patients with such tumors, we offer them what we call awake craniotomies. What does that mean? It means we keep the patients awake while we're doing surgery, and it's something that's done fairly commonly for tumors like this. We numb the scalp so the patient is not in pain, and then with them awake, we have tools to map out the speech areas, and areas that are identified as involved in speech production or language, we stay away from during surgery. And the areas that are not identified as speech areas, they're conducive to doing surgery. So that's how I would proceed with this patient. I would offer an awake craniotomy to map the speech. and resect whatever tumor can be resected safely.
Excellent. So the patient indeed underwent an awake craniotomy with language mapping, as you just heard about. As a result, a small part of the tumor could be removed safely without having that functional impact that Dr. Plakatanakis talked about. Sometimes after surgery, the brain is irritated, and you can get some seizures, which are typically managed with medications effectively. I'm going to just kind of, in the interest of time, move forward, talk about just this is what it looked like under the microscope. There's some telltale signs that all of us in the field look at, and we can see, even without some of the additional information about the genetics of the tumor, we can look at it, and it's supposed to look kind of like a fried egg. The cells look like a fried egg. I don't know if you can appreciate that. That suggests to us that this is a specific kind of tumor called oligodendroglioma. And as Dr. Plakatanakis mentioned, this also indicated just by the way this patient kind of presented, as we say, a young patient with seizures. This looked without an enhancing tumor. We suspected this was IDH mutant, that gene again, and indeed that was the case. And in fact, really oligodendrogliomas are always IDH mutant. And there's a characteristic genetic change in the tumor cells where two chromosomes, half of two different chromosomes is missing. We call that chromosome 1p 19q codeletion. So what was the treatment that was recommended for this patient, Dr. Kurtz?
So in low-grade gliomas, there are certain clinical features that help us make a treatment recommendation. So typically in patients that are older than 40, where the tumor has not been completely resected, we typically do recommend also a combined treatment approach, including radiation and chemotherapy. Based on the clinical studies that have been performed on these types of tumors, the recommended chemotherapy regimen is a regimen that is abbreviated as PZV. That's a 3-drug regimen, P standing for procarbazine, C standing for CCNU or lomustine, and V standing for vincristine. So I just want to briefly mention, of course, we always also think about clinical trials in this setting. In low-grade gliomas, there are not as many clinical trials available as compared to the glioblastoma space. But there may be clinical trials available that evaluate different radiation schemata, for instance, and then there may be clinical trials available at the time of tumor regrowth. But for this particular patient, we decided to move forward with the standard of care treatment, which is radiation plus the PCV chemotherapy.
Great. And Dr. Wong, can you comment briefly about how this radiation choice is different than the glioblastoma choice, or maybe how it's different in the way you give the radiation?
Yeah, so the radiation generally for low-grade glioma is less than what you would typically give for patients with a glioblastoma. Not to get technical, but the dose is slightly just lower. Also, the other thing that I'd point out is that typically I mentioned margins, or how much extra additional margin of radiation we typically give for glioblastomas. That also, with low-grade gliomas, I would typically give smaller radiation margins. It's typically like a centimeter or a centimeter and a half. Probably less. And then in terms of clinical trials, we definitely also would discuss, either radiation trials currently, which includes a randomization of photons versus proton therapy.
Yeah, one of the challenges with clinical trials in this patient group is that these tumors are very, very rare, and they number in the hundreds in the United States annually, these particular oligodendroglioma tumors. So very hard to do clinical trials to get the kind of numbers we need. Just not to gloss over, Minerva, can you just comment on for briefly what you would say, given that PCV chemotherapy is different than temozolomide chemotherapy, and what you might be counseling the patients?
Sure. So I will go over the schedule with them because they'll get chemotherapy on day 1, day 8, and then day 8 through 21, they have to take a pill at night. And then on day 29, they come in for an infusion. So I will go all over the dates with them. I will go over the side effects of this regimen. And I will bring them back probably on day 29 just to see how they're doing again. And order the next cycle of treatment. They will repeat MRI after 2 cycles of treatment. Each treatment is like 6 weeks long. And they know I am there to support them. They know how to get in touch with me through my chart, through a phone, and I'm there with them.
And Dr. Press, what might be the psychological support for this relatively young father who's in a very high-functioning career, very intense as well?
So again, he's likely to have the common emotional reactions of feeling overwhelmed, anxious, and depressed, but for this gentleman in particular, there's likely to be a change of his status, both at work and at home, as the primary breadwinner and a strong breadwinner. That's probably not going to be as available to him for at least a temporary period of time, so that we have to talk about what that feels like and what that looks like, and whether, in his case, how supportive his wife is, how understanding his children are, and his family, and to see if there's any other people in the community. And I just think it's so great that this team recognizes the mental health aspects of these diagnoses, that it is so normal to have an emotional reaction when you have a serious diagnosis, and that should be addressed, and it's important to address it so you get the best outcome possible.
Excellent. So this was the MRI the patient had now in December 2017, and everything looks stable. There's no new, again, that term enhancing tumor. Didn't have enhancing tumor in the first place. No new enhancing tumor. One thing we notice is that there's less pressure in the brain. Even so, you see that big white area. It's actually pushing the brain less. If you kind of look, oh, you're not seeing it for some reason.
Yeah, you're a little bit too far in front.
No, it jumped. Sorry. Yep. And so you see that those dark areas that are sort of curved, those are called the ventricles. There's fluid in the brain, and there's more space there than there was when the patient came in. If I can kind of jump ahead. The first time, I guess, well, I'm trying to see where it is. Yeah, here. So that's a positive result. Also, the patient, and again, more importantly, is how is the patient doing? How is the patient functioning? Because we really don't treat the MRI, and we don't treat the tumor, we treat the patient. And I think all of us recognize that. And so this patient is no longer having seizures, really no neurologic symptoms at all. So that issue with the hand numbness and coordination is gone. There's no speech problems. He's back working full-time, which is very important to his life. And his family is, he's doing well as a father, however a financial person can do as a father. I'm kidding. So again, another positive outcome so far in this case. So I think now we're going to shift to questions from all of you. So don't be shy. We're really here to help. If you are shy, though, don't feel badly. We will be happy to interact with you one-on-one. And we're going to hand out microphones. So we do have someone who raised a hand over here as well. And just keep the microphone close to your mouth so we can hear you.
Okay. I have a question about case number 1. The first tumor resection, how much of the tumor was resected? Was it 100% or less?
I think in that particular case, the tumor is a little unusual in that only a small component of the tumor is gadolinium enhancing, contrast enhancing, and most of the tumor is this non-enhancing bright cloud there.
Okay.
So in such cases, this is a glioblastoma. What we typically do is go after the gadolinium enhancing area, which is small, because the larger area is just way too large and too diffuse.
Okay. As far as mapping, there's no way to do mapping for vision, is there?
Most people do not do that. There are ways to monitor vision during surgery,
Okay.
but most people don't do that. So vision loss due to cortical damage from the tumor or the surgery, it's something that that patients can make up for.
Okay.
It's a more forgiving deficit, much more forgiving deficit than weakness or speech problems.
Okay, thank you.
Of course.
Just over here, and I think there was,
All right. I tend to talk too much, so if I'm talking too much, just tell me to shut up. I have no problem with that. Okay, I'm here as both a former patient. I've had 2 recurrences and 3 surgeries over the last 16 years. Still here. And also the friend of somebody who is currently, she just had her first recurrence 4 years after her initial surgery. Okay, one of my questions is the difference between, actually, let me start back. So my friend had, now that she's had her recurrence, she's been told to have PCV and radiation. And it's my understanding that PCV is a lot harsher than Temodar. She has the 1p19q deletions, and she's IDH1 positive. When I initially had my surgery and the testing, I was 1p19q negative, like I didn't have the deletions, but I was IDH1 positive. So I was still classified as an oligo. This was in 2003, because I think at that time the WHO didn't molecularly, because it had the fried egg appearance. And then my 3rd surgery was in 2015. And at that point, I think the WHO criteria had changed to more molecular. So I was diagnosed as an AA3. And I didn't do the radiation until after that surgery, because the Ki-67 had changed from initially 3 to 5% to 12%. So my question is, why after an initial surgery for someone who has 1p19q, would you do PCV and radiation as opposed to just Temodar alone?
so I just, before you respond to that, because it's a really good question, just thank you for sharing your experience. Go ahead. I think maybe both Dr. Kurtz and Dr. Wang should speak about that.
Yeah, so thank you again for sharing your experience and your friend's experience. And and that's a very important question. So what I want to point out is that, and I think someone said it earlier, it was maybe Nadia. So if you go to see different treatment teams and so forth, you may get different opinions, and that doesn't necessarily mean that the one opinion is more right than the other. It just means that the physicians and the clinicians that you see may kind of take the one or the other interpretation of the data that is available to them. So in the case that we presented here, we kind of really went down the treatment path that is published. And that we have the most data to back us up to. And that refers to a clinical trial that has started out in the 1990s and was finally published in 2016. The reason why it takes so long to do these studies, especially in the low-grade tumors, is that that is the IDH mutant 1p19q co-deleted oligodendrogliomas, or the IDH mutant non-codelated astrocytomas, right? The reason why it takes so long to do those studies is because these tumors, like patients actually can live very long with these tumors, and if the treatment is successful, there's a long time that these patients are being evaluated on a clinical trial. So until the data is really available to us as clinicians in order to guide us for treatment, a long time has already passed. And of course, during that time, the field has moved on and other treatments have become available, and these treatments may be thought-provoking. So the reason why I'm saying that is that in this particular treatment case, like the clinical trial that we're basing the recommendation for radiation and PCV on was started in the 1990s, and that clinical trial was written like that to do radiation plus PCV because the PCV was what was available at that time. We didn't have temozolomide yet when that clinical trial was designed. So yet the study, when it was finally published, clearly demonstrated that those patients who did get both, the radiation and the PCV chemotherapy, did do better than those who did radiation alone. Now, the question becomes, like in 2016, we of course know about temozolomide, and that temozolomide is successful for even higher grade gliomas, like the glioblastoma. And of course, the physician think about, well, can't you just use temozolomide in lieu of the PCV, and why do you bother with this old regimen that, as you were also saying, could potentially be more harsh. Nevertheless, it is what has been published, and it's like there's the most data. We don't have similar data that will say for the same tumors, like radiation plus temozolomide is equally effective than the PCV. These head-to-head comparison studies, they're currently ongoing, but we don't have those results available. So with that data in mind, like if you go to different clinicians, they may counsel you differently. So some clinicians will say, well, temozolomide, I have so much experience with it, it's so well tolerated, and it's working for higher grade gliomas, why would it not work for lower grade gliomas the same way? And that's why the treatment recommendation often can be radiation plus temozolomide. Other clinicians will say, well, you know, I want to stick to the data. I do know that this treatment regimen was successful in the clinical study, so I want you to have exactly the same regimen. I don't want that wiggle room or that question mark. Maybe I did do something different to you, and therefore will recommend radiation plus PCV chemotherapy for you. To comment on the harshness of the chemotherapy treatment, it is true that PCV is a little bit more harsh to the patient. There's a little bit more side effects that can be expected. Nevertheless, it can be well tolerated. And I have a lot of patients who do go through PCV chemotherapies and do actually pretty okay. Although it is a little bit more involved and, you know, than the temozolomide.
Okay, I have one more question about, because now that I've had the radiation after my second recurrence, I have to say that I did proton therapy, not the photon IMRT, and regardless, I have I finished in 2016, and I've noticed cognitive declines in certain ways. Short-term memory has, gotten worse over those years, and word retrieval is now becoming a problem for me. So I think, I don't know if people want to, or if you have an opinion that you tell your patients in terms of pushing off radiation, if that's something that you would do.
Go ahead, Tony.
You mentioned you got proton therapy, and as I mentioned earlier, and I don't know exactly if you had it sounds like you had a low-grade glioma.
Well, by the third surgery, which was the second recurrence, at that point, it was 2015, and at that point, they said it was an anaplastic astrocytoma, but initially, the first two times, they said it was an oligo.
Yeah.
But it was 1p19q intact.
So not knowing the exact details of the radiation treatment you got, as I mentioned, there is currently a study looking at low-grade gliomas, randomizing between protons and photons, and the goal of it is to see whether or not that type of therapy may reduce the neurocognitive side effects. And I emphasize the word reduce because I think people who do radiation oncology, Dr. Solomon, myself, recognize that all forms of therapy, whether proton or not, there's always that risk of that neurocognitive side effects, and I truly believe it really depends on the location of where we're going to radiate, whether the area that's radiated is near a particular spot in the brain called the hippocampus or hippocampi in this, it's hard to determine. And then, in my practice, a lot of patients, even with low-grade gliomas, my neuro-oncologists in general will defer radiation unless there's particular high-risk features associated with that. So yes. You mentioned about re-radiation for your friend. I don't know if that was
I'm
the
sorry.
case.
She's now on 4 years later, her first recurrence, and she's actually being treated here, or this is her. Well, no, she's being treated here, and the PCV plus radiation has just come up, and because of the 1p19q deletion and the IDH1 positive, she's still, I guess, considered oligo. I mean, a question of a second surgery is something she doesn't know about yet.
Yeah.
So she doesn't know what to do. And she calls me asking me all these questions.
Right. So not knowing the details of the re-irradiation or the reason or the size of the tumor, generally I do plenty of re-irradiation. obviously, but there are certain criteria I follow, generally with sort of national trials that have done re-radiations, and there's size cutoffs that we usually, use as eligibility off trial. So typically for re-radiation, I only consider for tumors that are, are focal and not too big. So
No, well, she personally, this was the first time that the radiation came up.
yeah.
Whatever.
So I'll just sort of sum everything up, and then we're going to have lots of time in the breakout sessions for additional interaction with our faculty, as well as an expanded group of faculty that have volunteered to be here today, which we're really grateful for. I'll just say that in this particular case, very challenging, difficult situation for you and for your friend, and I think all of us really work with the patient to weigh the risks and benefits of all the treatments. And that's really what it is, right? Every treatment, whether it's radiation, chemotherapy, and surgery, has a risk and a toxicity associated with it. And it's really, is that worth it compared to what's happening with the tumor? And I guess that's really where it stands. And so each decision is very, very individualized for that balance.
Is it okay if I ask 2 more questions that are general, that maybe everyone would
Do you mind if
benefit
we do it at the breakout session? We're running over time, I apologize. I'm getting the look from the ABTA here. So why don't you take over?